So welcome back to another episode of School of Airway. We're doing some airway basics now, at least Torah's basics. For this School of Airway, you gotta position the patient. And currently this patient is in what I call a coffin position. He's almost ready for death. I don't look now. Some people say, "Hey, there's a pillow there. I should use it like a magic pillow." This magic pillow will not align the airway, the oral pharynx, the pharyngeal axis of the the pharyngeal pharynx, and the trachea in this position. I have not maximized best exposure, glottic opening exposure for easier intubation. I haven't maximized or minimized the risk of aspiration. The stomach is, if it's full of coronas and White Castles, it's probably just as high as the trachea. And it can be if your belly is very distended from too much food chronically. People who are expert eaters, possibly the morbidly obese, or people with gastric paresis or an SBO, you are risking aspiration in this position. And in this position, you're maximizing atelectasis. So I think it's a lot easier with your lungs upright or closer to upright to ventilate, to oxygenate, even when the patient's actively breathing and awake. So we're going from this coffin position that some people are taught for intubation to a more of a urodosternal notch, aka ramp position, or if you use the term, the angle of Alexandria. Look very carefully. You have to be at the side of the bed to position the patient. And once you position the patient, you can start pre-oxygenating with high flow nasal cannula, BVM mask at 15 liters, nasal cannula at 15 liters. Alright. And this patient is not a trauma patient. Alright. You can try to use stethoscope almost like a lever and try to figure out if it's too high or too low. But you really need to go to the side of the bed and figure out the appropriate height. I will even say that I would even prop the head more. Of course, if this is a mannequin, I have a chance, pull him up to the edge of the bed so his head, if it's heavy enough, and some of these mannequins are not heavy enough in their head, that his head props over to the edge of the bed and provides even more mouth opening. This mannequin's mouth is always open, so that's not an issue. But in a live patient, this would be ideal for positioning. I'm using the stretcher. I'm not using linen. I'm not using all the linen in the ER or all the linen on a floor or in the hospital to position this patient. And this patient is not morbidly obese. He's pretty in shape for a sim man, for a mannequin. Alright? Now some will say, hey, what do I do for a patient who fell from 3 stories or hit by a truck or a train? He probably has a broken back, so many injuries, maybe a C-spine injury. So for that patient, I want to modify this positioning. Of course, his head won't be at the edge of the bed. This is just a mannequin, and I'm strong, so I can do this. Or I would actually elevate the patient, keeping his back straight. Now, because he has a suspected neck injury, I will try to get a seat collar, put it on him, how do I maximize his positioning? So his head is up and his belly is down. So I have an answer. Some reverse Trendelenburg. Alright. It's better than keeping him in the coffin position. His belly is now down. His head is up. Alright. again, we're doing this to try to use gravity, prevent passive regurgitation. The lungs can actually expand more, less atelectasis, right? And better view for intubation. And I've not caused any injury to his back, not caused any injury to his neck. Hope this makes sense. So again, this is possible in your trauma patient. Thank you.